So let's talk about the TNT trial. I like this trial a lot because it's not only an advocate for treating patients with a statin in general, but it makes a really good case for treating patients with high intensity statin as opposed to a lower dose. So we'll kind of see how that plays out as we go through it. The study was published in 2005 in the New England Journal of Medicine. It was a multi-centered, randomized, double-blind comparative trial that had 10,001 patients in it. And it looked at atorvastatin 10 milligrams directly to atorvastatin 80 milligrams. And the primary outcome they looked at was a composite of coronary artery disease mortality, non-fatal MI, resuscitation after cardiac arrest, and also fatal and non-fatal stroke. The inclusion criteria consisted of patients who were 35 to 75 years old that had CAD, and they defined that as having a prior MI, prior or current angina, or prior revascularization. Now the exclusion criteria was pretty long, and so I just included a few points here just so you can kind of get the picture. Patients that had an ejection fraction of less than 30, patients that were on other lipid modifying agents, patients that had uncontrolled diabetes or hypertension, which I thought was kind of interesting to include, and then patients that have active liver disease were excluded as well. So take a look at these baseline characteristics, and while you're looking at these, I want you to keep in mind that the patients in this study, first they went through a washout period where they stopped all lipid modifying agents including statins for about 8 weeks. And then from there, they were started on atorvastatin 10 for 8 weeks, and they had to have a cholesterol, LDL rather, less than 130 in order to be included and randomized. So these patients that you see here, these baseline characteristics are after they've already been on atorvastatin 10 milligrams. So an LDL of 98, blood pressure 131, non-HDL 128, HDL 47. If you kind of see where I'm going. If you look at the old guidelines and you are treating to just a cholesterol goal, let's say of less than 100, these patients would probably be categorized in that goal. You may be able to make a case, depending on what their past medical history is, to put them in a goal of less than 70, but realistically we could probably say these patients reach a goal of less than 100 and they would be okay. So looking at just the LDL, this person's already at goal. Granted, these are averages, but this was the person's numbers. They're already at goal, and so theoretically, we could just keep them on atorvastatin 10 milligrams. So that's one of the reasons I like this study because, and we'll look at the results here in a second, but you can kind of see where the new 2013 guidelines came up with treating more towards outcomes versus just strictly numbers. So looking at the results, the primary composite number needed to treat was 45. Stroke 125, non-fatal MI 77, and then any cardiovascular event, so that could have been stroke, MI, revascularization, heart failure hospitalization, TIA, any cardiovascular event you can think of that was included, not that you could think of, but that was included in the study, number needed to treat was 18. So the only thing is really that the major secondary endpoints that were looked at that were not significant was all-cause mortality and CAD mortality. Those things, when you take them just alone, then those did not reach significance. So these other kind of individual endpoints were the ones that were kind of driving this primary composite. And also heart failure hospitalizations had a higher number needed to treat of 111, but was still significant. And here's the other thing that I want to make sure we address. The adverse effects, I don't always include these in the study, but one of the big arguments against pushing someone to a higher statin level would be myalgias and the risk of rhabdo. And if you look, there was actually no difference in the two groups. And patients in the 80 milligrams, there was only 2 cases of actually confirmed rhabdo. And there was 3 cases in the 10 milligram group. So the only thing that actually came up that could be classified as a serious adverse effect would have been the LFTs. So patients had either a higher AST or ALT or both in the 80 milligram group, but it still was a number needed to harm of 100. So if you compare that in the previous slide, that any cardiovascular event number needed to treat of 18 versus a number needed to harm of 100, I think it makes a really good argument for treating patients with the higher intensity statin, even if their LDL is already lower than 100. So, I definitely want to hear the alternatives to this argument, and there's some people that really just like to continue to stick with treating towards a specific LDL goal. So feel free to list that in the comments or send me a message too, would be great. I'd love to hear your thoughts and opinions and kind of see how you use the results of this trial to base your recommendations on. Thanks.